Not surprisingly, the family physician, throughout his or her career, will often encounter patients with a plethora of diagnoses related to the thyroid or parathyroid glands. Often, it's the urologist who, in the workup of a patient with kidney stones, will find that the patient has hypercalcemia, and that workup subsequently results in the diagnosis of a parathyroid adenoma. Welcome to this presentation on the anatomy of the thyroid and parathyroid glands. At the conclusion of the presentation, hopefully you'll have a much better understanding of the anatomy of these important endocrine organs and their subsequent radiological imaging workup. Also note, there are about half a dozen PDF attachments to this presentation. We'll talk more about those in just a minute. I hope you enjoy the presentation. In addition to the information contained within this PowerPoint presentation, I've also attached several articles which you can find by downloading them under the paperclip icon. I've attached articles regarding the thyroid and parathyroid proper, as well as parathyroid disease and thyroid diseases. In addition, there's an article which I took the opportunity to pre-read and highlight for you on thyroid nodules. You can't really talk about thyroid and parathyroid disease without talking about what the presentation and workup is of a patient who could show up in your office with a neck mass. I've attached these extra readings here to help you read and understand more about what we're talking about. In truth, if you read all of these articles, you'd know pretty much everything there is to know about the endocrine of the thyroid and parathyroid diseases. I don't expect you to read them all. In fact, I know most of you probably won't read any of them, but those that do will score better on the exams. There are several important learning objectives that need to accompany this presentation. First and foremost, you'll need to understand the anatomy of the thyroid and the parathyroid glands. That includes, but is not limited to, the blood supply to the thyroid and parathyroid glands, as well as their gross anatomy. You'll also be able to understand various imaging techniques used to evaluate any of the pathology in the neck, most notably a thyroid ultrasound. In addition to knowing which imaging techniques take priority, you'll be able to interpret a thyroid ultrasound after reviewing the various videos which I've cut and edited and posted for you on YouTube. There are 2 or 3 videos which need to be looked at, and they're referenced within this PowerPoint presentation. Also, it's important for you to be able to trace the pathways of the recurrent laryngeal nerves, both the right and left, because they're a little bit different. And if this wasn't enough, I'll expect you to identify the appropriate cross-sectional anatomy of the neck on a CT or MRI scan. And remember, those images that you see on a thyroid ultrasound are basically cross-sections too. Of course, embryology is always important, and it plays a role especially in evaluating the blood supply to the parathyroid glands. You'll need to understand the embryological significance of the blood supply of the parathyroid glands, as those glands are related to the 3rd and 4th pharyngeal arches. You should also understand what a sestamibi scan is and what it's used for in the diagnosis of parathyroid disease, as well as the name of the chemical used for the sestamibi scan. And conversely, this is the same chemical used in a cardiac imaging stress test. You should also be able to trace out various potential locations that parathyroid tissue can be found. We often teach that there's only 4 parathyroid glands, but in reality, there can be up to 10. And the surgeon needs to know where they can all be found and those potential locations. As a family physician, you'll need to know that information too, because if you order the wrong imaging test, you'll potentially miss a parathyroid adenoma. Also, you'll be able to understand by looking at cross-sections of the neck relevant anatomical structures related to the thyroid and parathyroid glands. In addition, I'll want you to know the significance of the carotid body. Where is it located? What happens if it's manipulated? Are there malignancies of the carotid body? The carotid body is derived from what sort of tissue? There's a lot to learn here. As if that wasn't enough anatomy to know, I'll also expect you to understand and list the branches of the subclavian arteries in order moving from medial to lateral, and how that is important to understanding the blood supply to the thyroid and parathyroid glands. You should list the branches of the thyrocervical trunk You should also be able to understand the vascular supply to the thyroid gland, both the arterial and venous, as well as the lymphatic supply to the thyroid gland and parathyroid glands. You should also know what the thyroid eema is, and here we go with a little bit of medical history, and that is you should understand the relationship between Theodore Coker and the thyroid gland. You should also be able to tell me who Sandstrom was and what is his importance to the parathyroid glands, and tell me who Rosalind Yallow was. Remember, if you know who Henry Ford is and you drive a Ford, it doesn't make you drive it any better, but just knowing a little bit of history makes everything a little more credible. There's no difference here. When you're in the operating room and the surgeon asks for a Coker clamp, you'll be able to impress him and tell him who Dr. Coker was and what awards he won and why he won them. Just like world history, medical history takes its own relevant importance. If you know the history of medicine, just like world history, you'll be less inclined to repeat the mistakes of your predecessors. And besides that, it's just fun to learn the history. To round out this presentation, I'll also expect you to explain the 3 surgical zones of the neck and their importance. No, it's not only the surgeon that needs to know these things, because sometimes you'll be working in an urgent care and somebody will show up with an injury to the neck and you'll need to know what to do. Also, going back to embryology, I want you to be able to explain what a thyroglossal duct cyst is. Where does it come from, and then how is it related to the foramen cecum? And once you understand the anatomy of a thyroglossal duct cyst, as well as the embryology of it, what is a cyst trunk procedure? And what's weird about it? What has to be resected in order to prevent the thyroglossal duct cyst from coming back? A little more anatomy of the thyroid is introduced also. What is the Zukertubercle of the thyroid and where it's found? What's its significance? And every medical student is introduced to MEN syndromes. What are they? What pathologies do each of the syndromes contain? And describe the proper approach to a patient presenting with a neck mass. Remember, instant and open biopsies aren't always the way to go. Tell me what a branchial cleft cyst is or a branchial cleft fistula. Where are they and where are they usually found? And then tell me who developed the radioimmunoassay for insulin and how did that lead to the radioimmunoassay for parathyroid hormone, which is used today in the operating rooms, and what is the importance of this to endocrine surgery. Also note in the sidebar to this Adobe Presenter presentation that I've written multiple notes for you. Please make sure that you pay attention not only to the clipped on PDF files, but make sure that you read the associated notes with this PowerPoint file, whichever you choose. Rather than repost the schemes, which you already have access to, let's look at some of those schemes which this anatomy is applicable to for this course alone. Hypothyroidism, hyperthyroidism, a neck mass, a high calcium or a low serum calcium, phosphate abnormalities, weight gain or obesity, and of course weight loss. Interestingly, some of the schemes are not really clinical presentations. It would be very unusual for somebody to walk into your office and say, you know, doc, I've got high calcium, or my phosphate's out of whack, doc. Usually what happens is the specialist will see those patients after the blood tests have been drawn. Usually patients who present with hyperthyroidism or hyperparathyroidism present complaining of aches and pains or fatigue or not feeling well, and then that leads to a subsequent workup. Now look at all of the schemes throughout your clinical presentation model that hyperthyroidism and hyperparathyroidism and just simply the anatomy of the neck play in multiple various presentations throughout this curriculum. Anybody who presents with chest discomfort, for example, could have a substernal thyroid goiter, or heart palpitations could be related to hyperthyroidism. An abnormal chest x-ray could show a mediastinal mass related to a substernal goiter. Cough from dysphagia or shortness of breath could all be related to an enlarged thyroid gland. Hypertension, hypotension, abdominal pain is especially common in patients who present with hyperparathyroidism. constipation from hypercalcemia, diarrhea, nausea, vomiting, headaches, presenting with cognitive impairments, poor memory, poor thinking skills, seizures, a lump or a mass, or just general pain such as the mnemonic for hyperparathyroidism, stones, bones, groans, and mental overtones, and of course, kidney stones. So don't take away that the anatomy of the thyroid and parathyroid is only something you need to keep in store when you're presented with the schemes from the REM2 course. That simply isn't true. I'll be frank that in 21 years in surgical practice, I actually never saw a patient who had one of the MEN syndromes, multiple endocrine neoplasia. You'll get lectured on this in large group. However, take a look at this chart and you'll see that the anatomy of the thyroid and the parathyroid gland play an important part in working up somebody who you might have suspicions that may have an MEN syndrome. Looking at this list, we can see that a parathyroid hyperplasia or medullary thyroid carcinoma all play a role in this. So the anatomy of the thyroid and parathyroid glands and the subsequent histopathology can help you understand when someone presents to your office with vague symptoms such as excessive sweating or fatigue or a high calcium or a family history of medullary thyroid carcinoma that should be worked up by obtaining a serum calcitonin level. All of this is something you need to keep in the back of your brain as we look at the upcoming anatomy for these structures in the neck. So let's take a look first at the anatomy of the neck. You're familiar with the platysma muscle, and of course, if you look carefully, you'll be able to see the patient's external jugular vein and even their anterior jugular veins. Why are these important? Because when the surgeon goes to perform thyroid surgery, the very first muscle he cuts through after he goes through the skin is the platysma muscle, and then he has to ligate, usually, the anterior jugular veins. You'll be called multiple times if you go into surgery or internal medicine or do a rotating internship to put a central line in a patient's neck. You'll use the internal jugular vein, and occasionally you'll have to use the external jugular vein. This is the anatomy that's important superficially before we go deep. Take a look and make sure that you know these structures. In the previous picture, we saw the platysma, the anterior jugular veins, and the external jugular veins. What can you identify on this photo? I'm not going to point everything out here and circle everything because that's part of the challenge. You need to be able to identify these structures and identify them on a cadaver. So let's go through some of the things that I think that you should be able to see. Can you see the sternocleidomastoid muscle? Can you see the anterior jugular veins? What about the internal jugular vein, the external jugular vein? Can you see the submandibular gland? What about platysma? I'll be honest with you, I can't see platysma in this specimen, but see what you can identify and test yourself. Before we take a look at the thyroid proper, you should know that it derives its name from the word thyros. Thyros means shield. You can see how the faceplate of this knight's helmet pulls down over his lower face, and you'll quickly see the resemblance to the thyroid gland as it sits over the second to fourth tracheal rings. Thyros means shield, and thyroid also comes from that. It looks just like a shield. Let's take a look. But just before you turn the slide, take a second and click on the link above. At this point in the presentation, you probably need a break and at least a laugh. Here is the Black Knight fight from Monty Python's movie, Monty Python and the Holy Grail. I hope you get a chuckle out of it. All of these anatomical structures are, in theory at least, palpable. So for surface anatomy, you should be able to palpate the hyoid bone, you should be able to palpate the thyroid cartilage, the cricothyroid ligament, of course the cricoid cartilage, and you should be able to palpate, with practice, the thyroid gland. Most of you who are thin should be able to palpate the isthmus, but it takes time to learn to appreciate the palpation required for a thyroid gland. I think it took me several years before I was able to palpate with accuracy a thyroid gland, because as a surgeon it was my job to perform tracheotomies and cricothyroidotomies, and I didn't want to go through the isthmus because it bleeds like a stuck pig. Make sure that you can identify on yourself the hyoid bone, the thyroid cartilage, the cricothyroid ligament, the cricoid cartilage, and the isthmus, and it'll take you some practice. So here's a cadaver image of the thyroid gland, and again you can see how it looks just like the shield of a knight's helmet. Can you identify the various structures which you had just seen in the previous painting? I can make out not only the thyroid gland with its left and right lobes, I can see the isthmus, I can also see the carotids, I can also make out the sternocleidomastoid muscles, as well as the submandibular glands and a variety of the cartilages. There's a lot of vascular anatomy here, but most of it you already know, especially if we can break it down. You already know the brachiocephalic trunk, and as it gives off the common carotid artery, and of course in this case the left subclavian artery. As we move more lateral, that is moving from medial to lateral, we see the vertebral branch coming off the subclavian. We also see the internal thoracic going down behind the sternum and into the chest. Then we see the thyrocervical trunk, which gives off basically three branches. The suprascapular branch, which goes to the muscles beneath the scapula. And then it gives off a transverse cervical branch. And of course, a branch going to the inferior thyroid. It's self-explanatory that the inferior thyroid would supply blood to the thyroid, but it's the inferior thyroid which also supplies blood to the parathyroid glands, both the superior and inferior parathyroid glands. Make sure that you can at least trace this vasculature moving from medial to lateral. Remember, the subclavian turns into the axillary as it crosses over the first rib. Make sure that you click on the link below to a YouTube video which I posted. It shows a patient who has an almost bilateral palsy of the recurrent laryngeal nerves during thyroid surgery. You need to be able to trace the anatomy of the recurrent laryngeal nerves. The recurrent laryngeal nerves are branches of the vagus nerve, and on the right it recurs or wraps around the subclavian artery, and on the left it recurs and wraps around the arch of the aorta. Now, two very important branches, the external branch of the superior laryngeal nerve and the internal branch of the laryngeal nerve. The external branch actually innervates the cricothyroid muscle, and that helps to control abduction of the vocal cords. If the external branch of the superior laryngeal nerve, which is literally sometimes only as big as a spider's web, is damaged at surgery, the patient won't be able to abduct their vocal cord, and if both of these nerves are damaged, then the patient can't breathe because the vocal cords can't open. If the internal branch is damaged, the mucosa above the vocal cords can be damaged, and also taste and taste fibers to the posterior third of the tongue and to the epiglottis can be damaged. Please read the notes that I've posted with this slide. They're very important. So why do we actually care clinically about these recurrent laryngeal nerves? Well, if you're a singer and you've developed nodules on your vocal cords, or if you are also a singer and you need to have thyroid surgery, make sure that your surgeon is aware of the anatomy of the internal and external branches of the superior laryngeal nerves, because if they're damaged, your career is over. What if somebody has a lung cancer or a lung tumor which is pushing on one of the recurrent laryngeal nerves? Then the patient presents to your office with a cough, and you send them home and tell them to quit taking their ACE inhibitor, but you've forgotten that a tumor pressing on their recurrent laryngeal nerves is what's causing their cough or to be hoarse. Keep all of this anatomy in mind because it's clinically important. So let's take a second and review the anatomy on this slide. First and foremost, we see the vertebral artery, then the internal thoracic or the internal mammary artery. Then we see the thyrocervical trunk leading to the inferior thyroid artery. The superior thyroid artery can also be seen going to the superior aspect of the thyroid gland, and then we see the recurrent laryngeal nerves. On the right, it recurs around the subclavian artery. On the left, it recurs around the arch of the aorta. Then, of course, we see those all-important branches of the superior laryngeal nerve, the internal branch and the external branch. These always appear as board questions. Please make sure that you know the difference between the internal and the external branches of the superior laryngeal nerve and what they innervate respectively. Please read the comments that I've posted with this slide if you're unclear. Alright, well, you know most of this anatomy anyways. You can see the thyroid gland, and it's being supplied by the inferior thyroid arteries, which are branches of the thyrocervical trunks coming off the subclavians. We saw this in a previous slide. But there is an occasional rare artery which comes off either, in this case, the brachiocephalic trunk, or directly off the arch of the aorta, called the Thyroid Eema. If the surgeon isn't aware of this, it can result in excessive bleeding down into the mediastinum, and the patient can die. Even though it's weird, we have to be always understanding and cognizant of this small branch coming directly off the aorta. Here in this image, what's important is the thyrocervical trunk and its branches: transverse cervical artery, an ascending cervical artery, the inferior thyroid artery, and note how the anterior scalene muscle splits right between the subclavian artery and vein. I've spoken about this in other presentations before, but in somebody who's really thin, you can actually palpate this and use it as a landmark when you're putting a central line. If you don't remember this, go back and watch the presentation and the video which I posted showing a central line being inserted. So one more time, let's review the pertinent anatomy. First and foremost is the vagus nerve, then the anterior scalene muscle, then the suprascapular branch of the thyrocervical trunk. Of course, if you know the branches of the thyrocervical trunk, you'll then be able to understand the inferior thyroid artery, which supplies the parathyroid glands and the inferior aspect of the thyroid gland itself. Then the superior branch of the laryngeal nerve, which includes an external and an internal branch. And of course, the thoracic duct. The thoracic duct, if you remember, joins the confluence of the subclavian vein and the internal jugular vein. Using the previous slide as a reference, what can you identify here? What's the red arrow pointing to? I'll give you a hint. It comes off the thyrocervical trunk and goes to the inferior thyroid. See what else you can identify besides the thyroid gland, thyrocervical trunk, inferior thyroid artery, subclavian vein, and also see if you can note the anterior scalene muscle. You can even see the posterior scalene muscle and pieces of the brachial plexus. So now let's learn some of the branches coming off the common carotid. As the common carotid goes into the neck, it branches out into the external carotid artery and the internal carotid artery. A famous test question which you're going to be asked either as a first or a second year student, and definitely in the operating room by a surgeon, is how many branches are there of the internal carotid artery in the neck? It's a trick question. There are no branches of the internal carotid artery in the neck. Yes, there are branches of the internal carotid artery, but not in the neck. It's the external carotid artery which serves as branches. In this picture, and in a subsequent picture of a cadaver image, we'll see these branches a little bit better. Note how the glossopharyngeal nerve passes over the internal and external carotid arteries, and also note something called the carotid sinus and the carotid body. In order to prevent hypotension and bradycardia, when a surgeon operates on the carotid artery, they'll often inject the carotid sinus and carotid body with a little bit of lidocaine to numb it so that manipulation of the carotid artery doesn't result in the patient having subsequent bradycardia and hypotension from manipulation of the carotid body. It's difficult to discuss the head and neck anatomy without discussing the carotid body. This is a small body lying near the carotid sinus that is responsible for helping regulate pH and the body's response to changes in oxygen and carbon dioxide pressures in the atmosphere. The incidence of cancer in the carotid body is very rare, less than 1 in 30,000. But I did put some pictures here to show you an enlarged carotid body tumor on angiography, MR scan, and at surgery, so that you can see that this carotid body is actually very real. In a normal operative experience, the carotid body can rarely be seen. We inject the area around the carotid sinus very gently with lidocaine to prevent that bradycardia and hypotensive response. So again, what can you identify? Can you also find the first branch of the external carotid artery? I'll give you a hint. The first branch of the external carotid artery in the neck is the superior thyroid artery. See what you can identify in this picture. Make sure you read the comments on this slide, but also note something that I found sort of interesting, and that is we teach you that the first 7 cervical vertebrae also have foramina through which the vertebral artery goes through. I find it interesting that where the red arrow is, that is the foramina of C7, that the vertebral artery does not pass through that foramina. Note on this slide that the costocervical branch coming off of the thyrocervical trunk is not shown, and also the internal mammary artery on the left is also not shown. So don't get fooled by this image when you study and I ask you, what are the branches of the subclavian artery from medial to lateral? And you note on this image, 2 of those structures are actually missing. Refer back to the previous slide and see what you can identify here. I can see the common carotid, the internal carotid, the external carotid, the carotid bulb, and I can also see the first branch of the external carotid, i.e. the superior thyroid artery, going down into the neck. Can also note some of the vasculature here, most notably the digastrix and the omohyoid. You can also see the sternothyroid and the sternohyoid muscle. In this image, take a look at the accessory thyroid gland, and also note the middle thyroid vein, of which there is no accompanying artery. Here you can see anatomy which you already know. You can see the thyroid gland, the sternothyroid muscle, the cricothyroid muscle, the thyrohyoid muscle, as well as the internal jugular vein, the middle thyroid vein, and this plexus of vein which cover the thyroid gland. There's also a superior thyroid vein. But really what I want you to take away here is the accessory thyroid gland and where it's located, high up in the neck, just a little bit lateral to the midline. Remember, you're going to have lots of patients come into your office with neck masses, and not everything is a pimple, and not everything is a cyst, i.e. a sebaceous cyst. You have to think about the weird stuff too, like accessory thyroid glands and where they come from, as well as pharyngeal cleft fistulas or even thyroglossal duct cyst. We'll talk about all this in a minute. When a patient presents to your office with a midline neck mass, or even a mass just lateral to the midline, you'll be able to more intelligently assess this patient if you understand some basic embryology of the thyroid and parathyroid glands. Here is an image showing how the thyroid actually begins its descent into the neck from the foramen cecum. If you look at cadaver images of the tongue and the foramen cecum, you'll see an area at the posterior third of the tongue adjoining the anterior third of the tongue called the foramen cecum. The thyroid tissue begins its descent embryologically down into the neck, down towards the pyramidal lobe of the thyroid gland. And in some patients, they can actually present with ectopic thyroid tissue along this layer of descent. Some patients will require surgical excision of the pyramidal lobe. But if you understand that a midline structure, such as a thyroglossal duct cyst, can become infected, can become tender, enlarged, or even rupture, you'll be able to understand when a patient presents to your office with one of these midline structures that indeed it could be embryologically related to the thyroid gland and not a pimple or a sebaceous cyst. So this kid walks into your office and says, "Hey doc, I got a lump in my neck. What is it?" Mom's freaking out. She doesn't know what to do, and you grab your knife and say, "Oh, it's just a cyst. Let's go after it." Okay, you're wrong. But in this image, you know you're wrong because someone ordered a thyroid scan, and it shows atypical thyroid goiter, i.e. a little bit of ectopic thyroid gland above the wings of the thyroid, which you can clearly see in the nuclear scan. This is ectopic thyroid. And if it is symptomatic, meaning it causes hoarseness or dysphagia or pain, should probably be removed. Otherwise, it's probably of no consequence. So while we're talking about atypical thyroid goiter, let's mention all the places that the thyroid tissue can occur in ectopic locations. The child seen here who has the midline mass just below the digastric muscles most likely has a thyroglossal duct cyst, which is a remnant of the thyroid as it moves along the foramen cecum down towards its normal place in the neck. But the picture in the upper left shows thyroid tissue, which is in the posterior aspect of the tongue, lingual thyroid tissue. It can also occur in the tongue, and we can find it anywhere in the thyroglossal duct tract, as seen on the image on the right. This can result in a thyroglossal cyst. To completely remove this cyst, we need to not only make the incision and remove the entire epithelial line tract of the thyroglossal duct cyst, but we'll end up having to remove the middle portion of the hyoid bone. This is called a cyst trunk procedure. As you can see, thyroid can also occur in the pre-laryngeal area. It can appear behind the sternum and also even in the trachea. All of this relates back to the embryology of the thyroid gland as it descends from its normal pre-birth area at the posterior aspect of the tongue near the foramen cecum down into the neck. All of this makes sense if you've looked at your embryology textbook. Let's take a look at the pyramidal lobe of the thyroid. In many patients, when the thyroid begins its descent from the foramen cecum, we notice that it actually draws and appears to be connected to accessory thyroid tissue in way of a pyramidal lobe. There can be a connective tissue band adjoining it to the hyoid. The pyramidal lobe is a remnant of the thyroglossal duct. There can be an incomplete isthmus, along with ectopic tissue, a large pyramidal lobe, and an associated cyst. The treatment for a thyroglossal duct cyst to prevent recurrence is to remove not only the cyst, but the middle portion of the hyoid bone. This is called a cyst trunk procedure. S-I-S-T-R-U-N-K. Cyst trunk procedure. If you simply remove the cyst, excise it, drain it, it will come back. And you also have to be cognizant that accessory thyroid tissue, because it begins at the foramen cecum at the posterior aspect of the tongue, can also be found in sublingual tissue, even in the tongue itself. Ectopic thyroid tissue can be found anywhere along this tract that the thyroid begins its descent from the posterior tongue down into the neck. Keep this in mind when someone presents to your office, usually a child or a teenager, with a midline neck mass. Don't go charging in to drain, excise, and lance these. Work them up first and maybe do a thyroid scan. Here's an example of a thyroglossal duct cyst in a child. Child presents with either an infected cyst, which can be red, painful, warm to the touch, and tender, or sometimes, like this child, it's just a lump. Remember, it's in the midline. Always beware of structures anywhere in the midline, be it the forehead, the nose, the lip, the chin, or in the neck, because they're usually embryologically related structures. Thyroglossal duct cyst can be removed in this child by removing the cyst and the medial portion of the hyoid bone, called the cyst trunk procedure. And it would be nice to know if this cyst contains ectopic thyroid tissue by performing a nuclear thyroid scan. I would work this patient up also with thyroid function enzymes, although that's not entirely necessary if he shows no evidence of hypo or hyperthyroidism. That's a judgment call. This child should probably have a thyroid scan. He presents to the office with a mass subcutaneously just to the right of the midline. We know from our embryology that this could be ectopic thyroid, it could be a thyroglossal duct cyst, an epidermal inclusion cyst or a sebaceous cyst, or a small subcutaneous abscess. The possibility that this is ectopic thyroid leads us to work this up with a thyroid scan. So take this seriously. Any structure that presents in the midline that appears abnormal could be of embryological origin. Here on a cadaver specimen, we see what a thyroglossal duct looks like. Using the forceps, the anatomist is lifting up the thyroglossal duct, clearly showing the hyoid bone down towards the pyramidal lobe of the thyroid gland. Let's take a closer look. So, in the cadaver, here's a better view. You can clearly see number 5 is the thyroglossal duct, extending from number 6, the middle of the hyoid bone, down towards the thyroid gland, which is number 4. The question is this truly a thyroglossal duct, or is this pyramidal lobe of thyroid? Well, it's not entirely clear, but I am suspicious because it actually connects directly with the hyoid bone that this is probably a thyroglossal duct. The image in the upper right shows a patient who presented with a thyroglossal duct cyst, and it was inappropriately excised. The website where I obtained this photo from indicated that the patient initially had an infected thyroglossal duct cyst. It ruptured, was packed, healed over, and then ruptured again before it was opened and drained. You can imagine the difficulty by opening such an incision, realizing that it connects with thyroid tissue. In the picture on the right, lower aspect, we see a patient who has an undrained thyroglossal duct cyst. Again, you can see how this could be confused to an untrained eye for a epidermal inclusion cyst or a sebaceous cyst. But you have to always remember that any structure in the midline of the body could be embryological in origin, in which case the diagnosis must be entertained of ectopic thyroid, thyroglossal duct cyst, epidermal inclusion cyst, or a subcutaneous abscess. Both of these patients should have had a thyroid scan before any operation was done. So, in case I haven't emphasized it enough, remember that you need to be aware of any structure in the midline, whether it's on the forehead, the nose, the palate, or in the midline of the neck. A thyroglossal duct cyst requires that the middle segment of the hyoid bone be removed, along with the thyroglossal duct. You can either remove it or ligate the duct, but you must remove the center portion of the hyoid bone and the associated connective tissue. Don't lance this, because doing so will give you a poor cosmetic effect and it'll make you look stupid. Well, you know the arterial supply to the thyroid gland. What about the venous supply to the thyroid gland? Well, it comes off the internal jugular vein, mostly by way of middle thyroid veins. Notice that's plural. Notice in this image how the middle thyroid veins actually supply a superior and an inferior portion of the thyroid gland. It's not like there's just one middle thyroid vein. Why didn't, in this image, they call it a superior and an inferior thyroid vein? I don't know. I didn't name it. But this is one of the weird areas in the body that the arterial supply doesn't necessarily follow the venous supply. There's a multitude of thyroid veins covering the thyroid gland, and of course, you can see the various anatomy which you already know. The subclavian vein, the internal jugular vein, the left brachiocephalic vein, and the middle thyroid veins. So keep this in mind as we work through the presentation. I know it seems overwhelming, but again, I've circled those structures that I think that you need to know and to remember. For example, you can see the thyroid gland, but you also need to understand its proximity to the recurrent laryngeal nerves. Also understand that the thyroid gives way to venous drainage from the inferior thyroid veins. And before that we can get to the inferior thyroid veins, we had to cut through the platysma muscle and the anterior jugular veins. Of course, you've seen the external jugular vein. Here's the cricoid cartilage, and above it, the thyroid cartilage. And the middle thyroid vein, of which there is no corresponding middle thyroid artery. You can also see some of the cervical nodes that are adjacent to the internal jugular vein, as well as the various muscles. And we have already reviewed the importance of the anterior scalene muscle previously, where it goes between the subclavian vein and subclavian artery. Again, using the image in the previous slide, what can you identify here? Take a look and see if you can find all of those venous structures which we just spoke about. Here's an image which you've already seen. Again, take a look and see what you can find. Try to identify not only the glandular structures, but the arterial and the venous structures. What about the lymphatics to the neck? Whenever you go see the physician, they always reach up and palpate your neck, and they always feel mostly on the anterior borders of your sternocleidomastoid muscles. That's because the jugular chains are located there, and those are where most of the lymphatics lie. In fact, the lymphatic flow, as you can see from this image, usually is sweeping from midline to lateral to the jugular chains. So it's not so important that you know for sure that there's a pretracheal node or a submandibular node. Just know that the flow is usually from medial to lateral to that anterior jugular chain. So when you perform your physical exam, it's very important that you palpate these nodes, because statistically these are the ones that are going to be positive if there's cancer or an infection. Again, just more of the same, but here on the left side of this slide, note how the lymphatic drainage from the head and the lateral side of the face drains into the preauricular nodes, which then drain down into the jugular chain. Then, of course, we know that they eventually will drain into the thoracic duct on the left and the right lymphatic duct on the right. Keep all this in mind when you perform physical exams on your patient. The suboccipital node, which you can see here, is not very often involved with infections because this is a rare source and a rare site of infection in the posterior aspect of the neck, but it can become inflamed. Here's another image from the Eema Atlas, which I think shows it more clearly. Note that the facial drainage goes into the parotid area and to the preauricular area. The occipital nodes drain down posteriorly, and eventually everything sweeps down to the anterior jugular chain or the posterior jugular chains. And of course, then they drain into the subclavian veins. So how often are you going to actually palpate an occipital node? Not very common. They are, and they can be palpated in cases of severe infections of the neck, cancers of the head and neck, but it's uncommon. So when you perform your physical exam, palpate those lymph nodes in the anterior jugular chain and the posterior jugular chains. So looking at this image from VH Dissector, you can see an anterior jugular vein, the thyroid, the trachea, the esophagus, the internal jugular veins and the common carotid artery, sternocleidomastoid muscles, and the strap muscles, those muscles of the sternothyroid or sternohyoid. Collectively, surgeons simply call them the strap muscles because they have very little clinical significance. Let's take a look at more images from VH Dissector in these cross-sections to help you understand the cross-sectional anatomy and how to read a CT scan of this area of the neck. So here we go. You can see the thyroid gland, which I've colored purple. What else can you name? Take a look and make sure that you review the PowerPoint so that you can see everything that I've circled and put arrows by, because I'll hold you accountable to be able to read such a cross-section on your exams. Once again, you can see the trachea, the overlying thyroid gland, and the red common carotid arteries. There's also an area in the right lobe of this thyroid gland, which I've circled, which is a little abnormal. This cadaver probably should have had an ultrasound of his neck, or at least an aspiration of this area of his thyroid, because it looks a little unusual to me. Here's a test which we don't really use anymore. It is on occasion used, and it's a nuclear scan of a thyroid for a thyroid goiter. In this case, the patient presents to the physician's office complaining of a mass in her neck, and on palpation and probably ultrasound, it's suspicious for a mass within the thyroid gland. Notice this is a test for the thyroid and not the parathyroid. Usually the radioactive nuclear study of the thyroid scan, called simply a thyroid scan, is done and will show an area of increased activity called a hot nodule if it's a benign hyperfunctioning goiter. If the area is a cold nodule, which means that it does not show up on the nuclear scan, it has between a 20 and 50% chance of being malignant. The reason that we don't do this test very often is if a patient like this were to present to my office and physical exam and ultrasound would suggest a nodule within her thyroid, I would simply perform a fine needle aspiration or a fine needle biopsy of this mass and send it to the pathologist for cytology. There really is no need to perform thyroid scanning anymore as long as ultrasound-directed biopsies and cytology can be obtained in the doctor's office. There are exceptions. The scan still is done, but today's technology means it's done less and less. Now that I've mentioned thyroid ultrasound, let's take a look at one. You'll learn more about how to read a thyroid ultrasound if you watch presentations labeled on the next slide. Zukertubercle tubercle is a pyramidal extension of the thyroid gland present at the most posterior side of each lobe. It's an embryological remnant of what would have been a posterior lobe. Emil Zukertubercle described it in 1902 as a posterior process of the thyroid gland. Interestingly, it's believed to have some clinical significance since it's related closely to the recurrent laryngeal nerve, which usually lies in the tracheoesophageal groove, the inferior thyroid artery, Barry's ligament, and the parathyroid glands. There is significant anatomic variation of Zukertubercle's tubercle. If you remember, we spoke about the blood supply to the parathyroid glands, how they arise from the third and fourth branchial arches. The inferior thyroid artery provides blood supply to the parathyroid glands, but it's the inferior parathyroid gland which arises from the third branchial arch and moves towards the neck around the superior gland which comes from the fourth pharyngeal arch. There is also pathology as a result of this descent in the neck. These are called branchial cleft fistulas or branchial cleft cysts. The picture at the bottom shows an image of a patient presenting with a neck mass on the right side of the neck. To the untrained eye, this might look like mumps or an enlarged submandibular gland or perhaps an abscess. But if you know your embryology, you can be aware that this could be a branchial cleft fistula or a cyst, in which case total excision is required. Just like parathyroid tissue can be found in the thyroid proper, but usually in the tracheoesophageal groove, locations for branchial cleft sinuses or fistulas are usually found along the anterior border of the sternocleidomastoid muscle. This image is showing the most common locations of branchial sinuses or possible branchial cleft cyst. Sometimes these cysts even have openings and drain to the external skin. They need to be completely excised, but should be worked up thoroughly before you reach for the knife. If they're behind the sternum, the patient may require a median sternotomy to completely excise this cyst or sinus to keep it from recurring. This slide is mostly to remind me that what's coming up now is a discussion of the parathyroid glands. You'll see pathology of the parathyroid glands when the patient presents to you with stones, i.e. kidney stones, bones, meaning bone pain, moans, meaning pain and unexplained fatigue, and mental overtones, complaining of difficulty in cognition, thinking, confusion. Stones, bones, groans, and mental overtones can be related to parathyroid disease, and hyper or hypocalcemia. So let's take a look at this anatomy. The parathyroid glands were the last major glands to be recognized in humans back in the 1880s. It was a medical student who first discovered them, Ivar Sandstrom. Is this somebody you should commit to memory? Well, not necessarily, but you are going to be doctors. So knowing who discovered the last organ in the human body is kind of cool. Ivar Sandstrom is responsible. What's interesting is that he only lived to the ripe age of 37. We usually teach that there are 4 parathyroid glands, 2 superiorly and 2 inferiorly. That's not really true. You can have parathyroid glands which are usually found in the tracheoesophageal groove, but they can also be found within the thyroid. They can be found within the thymus. They can be found in fatty tissue behind the substernal notch, anywhere in the neck. Usually there are 4, but there can be upward of 10. Keep this in mind. In this image, we're looking at a posterior view of the neck. You can see the constrictor muscles which help you swallow. The esophagus can also be seen, and the posterior tracheoesophageal groove. And in this case, the parathyroid glands are actually not in the groove, but are on the posterior aspect of the thyroid gland. Here's all the places that you can find parathyroid glands. Some high up in the neck, some within the thyroid gland, some behind the sternum. Note that about 38% occur in the tracheoesophageal groove or within the posterior thyroid. 20% occur also within the thyroid proper, but a little higher in the thyroid gland. Statistically, you need to be aware that these parathyroid glands can occur mostly in the tracheoesophageal groove or in the superior lobe of the thyroid or the inferior lobe of the thyroid. But on your sestamibi scans, and we'll talk about that in a minute, if it looks like they're not in the typical location, you might want to be sure and consult the appropriate surgical referral. Here's a little cleaner image of what we just looked at. Note the 4 parathyroid glands on the posterior aspect of the thyroid. The parathyroid glands are usually supplied from the inferior thyroid artery and not from the superior thyroid artery. This is from an embryological twist. The inferior parathyroid glands come from the 3rd pharyngeal arch, and the upper superior parathyroid glands come from the 4th arch. The inferior parathyroids from the 3rd arch descend into the neck, and in doing so move past the 4th pharyngeal arch and the superior thyroid. It's because of this that we have this blood supply to the parathyroid glands from the inferior thyroid artery. What's the clinical significance of this? When the surgeon is taking out a thyroid gland, he would like to preserve the inferior thyroid artery, because if he doesn't, the patient can have postoperative hypocalcemia. He could end up killing the parathyroid glands. Inferior thyroid artery should be preserved at the time of a thyroidectomy, as well as, of course, those recurrent laryngeal nerves and their branches. Here's an image from a web link which is located at the bottom of your page showing multiple parathyroid glands which have been removed. Normal parathyroid gland is about the size of a pea. These represent thyroid adenomas, benign tumors causing hypercalcemia in patients. At surgery, sometimes we can't tell if it's a parathyroid gland or a lymph node, and we have to ask the pathologist to do a frozen section, freeze it, split it, look under the microscope, and tell us if it's a lymph node, a piece of fat, or if we got the parathyroid adenoma. Surgery's a little more difficult than that, and we can use intraoperative parathyroid hormone assays to help us and tell us whether we've actually removed a parathyroid gland, but it's not always clear-cut. Here's a histological image of a parathyroid adenoma from one of my own patients. You can see there's a fair amount of fat within the parenchyma of the specimen, and a fair amount of activity seen throughout each of these cells. This is not cancer, but was a parathyroid adenoma. Your pathology lectures will cover this in much more detail. Here, In this cross-section, you can see the thyroid gland, the isthmus, the trachea, the posterior line esophagus. You can even see in this image the parathyroid glands, although I'll tell you that that's just impossible to see on CAT scan unless they're large. You'll need to know this cross-sectional anatomy, not only to look at a CT scan, but for your upcoming exams. Note how the jugular vein appears about 2 to 3 times the size of the common carotid artery. This is pretty classic of the venous system in the body. Usually the veins light up because of the intravenous contrast. We'll talk about the use of intravenous contrast and the fact that it contains iodine and how that can screw up your test for the thyroid. So before we go on, let's quickly review the important cross-sectional anatomy. In this study, I'd like you to look and make sure that you can recognize not only first the thyroid gland, but the trachea, and then work from what you know to what you don't know. Notice the internal jugular vein followed by the common carotid artery, and then the parathyroid gland. Make sure that you can identify all of these structures in a cross-section, because when you go on to learn cross-sectional anatomy via ultrasound or CAT scan, it'll be important that you recognize these readily identifiable anatomical structures. So by now you have a good image in your brain of just exactly how small the parathyroid glands can be. They're about the size of a pea, sometimes smaller. If a patient has a parathyroid adenoma or a benign tumor of one of the parathyroid glands, they can range in size from a pea all the way up to a large marble and perhaps even the size of a baseball. How exactly do we find such a small, tiny piece of tissue? Well, only recently has the recommendations changed for the surgeon. It used to be in the 1960s, 70s, and 80s, even the 90s, that a surgeon was required to explore the neck for all 4 parathyroid glands prior to removing any, whether he's looking for a parathyroid adenoma or hyperplasia of all the glands. The surgeon was required to look for all 4 of them. But today, things are different. With the sestamibi scan, using technetium-99, the same chemical which is used for a cardiolite stress test on the heart, the surgeon is better able to identify and localize an abnormal parathyroid gland. In this image, you're looking at a sestamibi scan that's positive. On the left, we can clearly see the thyroid gland light up, and on the right, I've circled the parathyroid adenoma in the patient's right lower neck. It doesn't exactly tell us where this adenomatous tissue is. It's not exact, but it at least gives us enough information to know that the parathyroid adenoma isn't in the chest, it's probably not behind the sternum, and this patient probably is an operative candidate. This will save the patient usually an exploration of both sides of the neck to look for all 4 parathyroid glands. A sestamibi scan has allowed the surgeon to perform minimally invasive surgery for parathyroids. Interestingly, just 10 years ago, this really wasn't the case. Today, the combination of ultrasound, sestamibi scanning, and even CAT scanning can help localize where an abnormal parathyroid gland is. A sestamibi scan is a study which you'll want to add to your armamentarium. Here's another image taken from one of my own patients. Actually, in both, you can clearly see the abnormal parathyroid tissue. But on the right, it's circled, and you can clearly see this parathyroid adenoma. On the left is an image of the parathyroid adenoma stacked on the visualized thyroid gland. The image that we're actually looking for to make a positive sestamibi scan is the one on the right, the subtraction image. In this patient, I operated on them and found a single solitary parathyroid adenoma in the right lower neck, exactly where the scan said that it should be located. Again, we're looking at a sestamibi scan taken from one of my patients from 2007. On the left, you can clearly see the thyroid with the parathyroid adenoma localized, and I've drawn a red circle around it. The subtraction image on the right, i.e. where we remove the radioactive image from the thyroid and leaving only the parathyroid adenoma showing, clearly shows us that the patient is most likely suffering from a single solitary tumor of a parathyroid gland and not from parathyroid hyperplasia. I will tell you that in the operating room, we are always cognizant that a parathyroid adenoma could be multiple, or the patient could have both, a parathyroid adenoma and hyperplasia. So we usually remove the adenoma, and sometimes we'll biopsy another gland just to make sure that we're not dealing with hyperplasia. Every surgeon is a little bit different in how they approach this situation. Here's another image. This is not from any of my patients, but it does clearly suggest a parathyroid adenoma. In the image in the upper left box, what appears to be an elongated left lobe of the thyroid gland is in reality, on the subtraction image, a positive test for a parathyroid adenoma. Interestingly, if you look at the box in the left lower corner, you can see a little bit of radioactive tracer activity in the right thyroid lobe, most notably in what appears to be probably the middle area of the right upper lobe of the thyroid gland. This is a positive sestamibi scan strongly suggesting a single solitary adenoma where the red arrow is showing in the left lower neck. However, there's just enough radiotracer in the right thyroid to make me suspicious in this patient that they could have hyperplasia or even another parathyroid adenoma hidden within the parenchyma of the thyroid gland. The surgeon has to be cognizant of all of these possibilities. Here's a CAT scan of a patient who has a very large parathyroid adenoma in the chest, just above the carina. In this patient, the CAT scan reveals the parathyroid adenoma to be in a surgically and technically difficult area for removal. This patient will require a median sternotomy in order to remove the parathyroid adenoma. This parathyroid adenoma has grown so large that the center of it is becoming necrotic. This is an excellent example of how parathyroid imaging is necessary before one begins to explore the neck. In this patient, if we had performed an ultrasound and looked in the neck for parathyroid hyperplasia without looking for an adenoma or other tissue causing the hypercalcemia and doing this CAT scan, the patient would have had a neck dissection which would have yielded no findings. In this patient, the CAT scan was absolutely necessary. So with all of the anatomy that you've learned in the neck, which has actually been at this point in your medical career fairly extensive, what exactly do we do to the patient who presents with an injury to the neck? Surgeons are inclined to reach for the knife if a patient has been stabbed in the neck proper, or if they've had an impalement injury, or a laceration, or a stab wound. Any type of trauma, either on purpose or inadvertent, usually makes the surgeon explore zone 2 of the neck. Zone 2, which this picture shows, is usually explored because it's easily accessible. Here we can see the thyroid cartilage, the cricoid cartilage, the thyroid will be here, as will the trachea, the carotid artery, as well as the internal jugular vein, the vagus nerves and the phrenic nerves, the recurrent laryngeal nerves. However, if the patient presents with an injury, a stab wound or a gunshot wound to zone 1 or zone 3, these areas are difficult to get to in the operating room. We usually perform arteriography for zone 1 or zone 3. We take a picture of the blood vessels to see if there's any vascular injury in zone 1 or zone 3. If there is, we'll have to explore and operate. If there isn't, we usually can observe the patient, since it's a vascular injury that will usually get a patient in trouble in zone 1 or zone 3. Of course, zone 2 could result in damage not only to all of the structures seen here, but to the esophagus, and that should be explored immediately. So just remember, there are different surgical approaches to the areas of the neck, providing that you understand this anatomy. Here's a perfect example of the clinical necessity of the previous slide. This patient has a stab wound to the neck. This should be removed in the operating room under direct visualization, and any injuries should be thoroughly explored in the operating room. Assuming that this knife actually isn't 2 feet long, he probably doesn't require any arteriography to look for damage to vessels in Zone 1. Zone 3 appears to be uninvolved. So this is relatively easy. We need to explore this patient looking for damage to the carotid, the jugular vein, the thoracic duct, the esophagus, any of the vascular structures, the thyroid gland, and we need to explore this expediently, giving the patient probably a tetanus shot as well as preoperative antibiotics. But you don't need to know all of that at this stage of your medical career. What you do need to know is the thyroid involved? Is the esophagus involved? Is the trachea involved? And the vasculature of the neck? Let's go explore it. It's in Zone 2. Now that you pretty much know all of the anatomy of the anterior neck, what's going to happen if a patient needs an emergent airway? Well, you can perform cricothyroidotomy, which is an incision in the cricothyroid membrane, or you can perform a tracheostomy. Tracheostomy is a permanent opening within the trachea itself to allow for placement of a tracheostomy tube. A tracheotomy is a temporary hole in the trachea. So here we have a patient which has an incision in her trachea, retracting the infrahyoid muscles and incising the isthmus of the thyroid. The thyroid can be very bloody and can get in the way. In an emergent procedure, the incision is made vertically because you want to avoid the anterior jugular veins. Remember those from the first couple of slides? So let's imagine that you're sitting on an airplane and someone begins to cough and then they lose their airway from choking. You do the Heimlich maneuver, you can't get it removed, and now you're forced with having to make a hole in their neck. You're a medical student or now you're a resident, they're going to look to you to do it. Make a vertical incision to avoid the anterior jugular veins, stay in the midline, divide the strap muscles, and poke a hole in the cricothyroid membrane, which is below the vocal cords. The risk of the procedure: bleeding, especially if you nail the thyroid or the isthmus, damage to the vocal cords, damage to the external branch of the recurrent laryngeal nerve, the superior nerve that is, and possibly bleeding or even damage to vocal cords or loss of airway. But you don't have a choice. This patient's choking, they need an airway. Vertical incision, avoid the anterior jugular veins, poke a hole in the cricothyroid membrane, and you've just performed your first cricothyroidotomy. It'll later be converted in the operating room to a permanent tracheostomy. You know I love surgical history and medical history. Here's a perfect example. Theodore Kocher won the Nobel Prize in 1909 for his work on the thyroid gland, including thyroid surgery, thyroid hormones, and even the study of cretinism. There's a Kocher clamp named after him, and that's used, surprisingly, on thyroid surgery and also throughout the abdomen. A Kocher incision is a right subcostal incision used to remove gallbladders, and a Kocher maneuver is used to mobilize the duodenum in the retroperitoneum to move the duodenum medially so that we can palpate behind the duodenum and feel the pancreas, where it nestles the head of the pancreas into the C-loop of the duodenum. You will hear all of these in your surgical rotations. You'll need to know that Theodore Kocher had a mortality rate of between 18 and 50% on his first thyroid operations. Almost half of his patients died because of blood loss. Probably the good old Thyroid Eema artery got loose from him and he couldn't control it. Also highly possible that his patient suffered from hypocalcemic tetany. While he removed the thyroid glands, he most likely, unknowingly, removed the parathyroid glands too, and his patient suffered from hypocalcemia. But that didn't keep him from winning the Nobel Prize. You're going to hear about this in the operating room. You're going to need to know who Theodore Kocher was. You're going to be asking for the Kocher clamp, a Kocher incision to take out the gallbladder, and even a Kocher maneuver to help a dislocated shoulder. You're going to hear a lot about Theodore Coker, whether you choose to go into surgery or not. I've used a multitude of references in putting this Adobe Presenter presentation together for you. Please make judicious use of each of these references, including the videos which I've posted on YouTube from my own personal patient collections. Also use judicious use of Dr. Ackland's videos. And if you have any questions or comments, please email me. I hope you've enjoyed the presentation and have had the opportunity to digest some of the recommended readings.